name is Meg Murray, and I'm the CEO of the Association for Community Affiliated Plans, otherwise known as ACAP, as well as a proud board member of the Alliance for Health Policy. At ACAP, we like to say that Medicaid is us, and by that I mean we're the leading association advocating for Medicaid, Medicaid beneficiaries, and the safety net health plans who serve them. Because of our strong support for Medicaid, one of the main things we'll be working with the new Congress and the new administration is to make sure that there's adequate funding for Medicaid, particularly during the pandemic. We will be looking for the new Congress to support increased FMAP during the pandemic, as well as to have a trigger so that the Congress has already decided that FMAP should be increased the next time we have an economic cataclysmic event like we have right now. We will also be working with the new Congress and the new administration to end the proliferation of junk insurance. The current administration has allowed these plans to be sold for up to 3 years. We believe that many beneficiaries will be snookered into buying these, which do not have all the protections of the Affordable Care Act, and we want to make sure the consumers are protected. So that's what we will be working for with the new Congress and new administration, and I look forward to hearing the discussion today.
Hello, and welcome to the third session in the Alliance for Health Policy 2020 Signature Series Post-Election Symposium. I'm Sarah Dash, President and CEO of the Alliance. And for the listeners who are new to us, welcome. We're a nonpartisan resource for the health policy community dedicated to advancing knowledge and understanding of health policy issues. Thanks for joining us today, where we will continue to grapple with the devastation of the ongoing COVID-19 pandemic and how the election results could influence the health policy agenda in 2021 and beyond. Since election news and results are still updating, please note that we're recording this on Monday, November 16th at 2 p.m. Eastern, in case anything has changed between now and when we broadcast. I'd like to take a moment to thank our 2020 Post-Election Symposium sponsors for supporting this event. And I also want to highlight our upcoming session where we will discuss the gaps in our healthcare system that COVID-19 exposed and how that will impact the priorities of the incoming administration, Congress, states, and federal courts. You can also find recordings of yesterday's discussions on our website and materials that accompany all of our sessions at allhealthpolicy.org. And now it's my pleasure to introduce Dr. Ian Morrison, a New York Times bestselling author, consultant, and futurist, specializing in long-term forecasting and planning with an emphasis on healthcare. Dr. Morrison currently serves as senior advisor to Concord Health Partners and on the advisory council of the Council of Accountable Physician Practices. Dr. Morrison has previously served as president of the Institute for the Future and as a founding partner at the Strategic Health Perspectives, which is a joint venture between Harris Interactive and the Harvard School of Public Health Department of Health Policy and Management. Prior to his time at Strategic Health Perspectives, he served as the chairman of the Health Futures Forum. Well, Ian, we're so grateful to have you here today to provide your insights on what you think we can expect next year and beyond. And with that, I will turn it over to you.
Well, Sarah, thank you so much for having me, and it's an honor to be with such distinguished faculty and a wonderful program. As you mentioned, I'm known as a futurist. My definition of a futurist is an economist who couldn't handle the calculus. I'm in the sweeping generalization business and have been for a very long time. And the number one question I always get asked is, how do you become a futurist? I point out that my undergraduate major at Edinburgh University was Geographic and Economic Change in Scotland, 1580 to 1830. Which is incredibly useful, but actually is a useful training. I've been a student of structural change in society now for almost 50 years, and I ended up working in healthcare. Ironically, I was trained as a geographer and urban planner, moved to Canada, and then was working on my doctorate, and I got offered a job to join the Institute for the Future, the modestly entitled Institute for the Future, to work on a grant called Looking Ahead at American Healthcare that Bob Blendon, when he was at Robert Wood Johnson, had given the Institute. And I got a chance to work with Bob in 1985 and pretty much ever since. And we have been close colleagues, and I've learned so much from Bob Blendon over the years. But I've spent most of my time in the last 20 odd years working with health systems and healthcare stakeholders across the spectrum the ecosystem and continue to do so. And I wanted to sort of share some comments about where I see the industry and particularly the impact of healthcare or the impact on healthcare of the COVID pandemic. So if we could go to the next slide. I think that I've been a sort of student of the post-industrial economy now for 40 odd years. And if there's one hallmark of post-industrial society, it's the widening income gap between haves and have-nots, particularly the top 1%. I say to my kids, be in the top 1%, you'll do just fine. But these effects are also compounded by race and racism here in the US and in many other countries. Next. And when it comes to healthcare, if we look at the next slide, the one kind of mega trend, if you like, that we've been watching over all the time I've been in the US, which is now 35 years, is the progressive unaffordability of healthcare, particularly in terms of out-of-pocket costs. I mean, the American public, in my view, could care less how much it costs as a share of GNP, but they worry about what they pay. And one tracer condition that, I was on the board of the California Healthcare Foundation for a decade, and we did a little study back in the day that showed that in 1970, if you provided health benefits for a family, it cost about 10% of the minimum wage. Today, that equivalent number of health benefits for a family is 150% of the minimum wage, which really speaks to the progressive unaffordability of healthcare. Next, please. And I mentioned the California Healthcare Foundation. Back in 2005, Mark Smith, the then CEO, I was on the board, and Mark invited me to join a meeting with Ulla Schmidt, who was the German Minister of Health through much of the early 2000s. And she was on a listening tour trying to understand how American healthcare worked. And Mark and several of us were gathered to talk about trends in American healthcare. And we got to the part in the conversation about money. Oh, by the way, she didn't speak any English, which was a bit difficult. But actually, she had this translator guy who did simultaneous translation. So we actually got along fine. And we're in the part of the conversation where we're talking about the money. And I was sort of explaining and waxing lyrical that the way it works in America is that we doctors and hospitals charge some multiple of what it actually costs to deliver the service, maybe 2 or 3 times as much, to make the math work because of the perceived underpayment by public payers. And I don't speak German, but I believe she said, "What the, expletive deleted." And she's right, because if you go to the next slide, one of the hallmarks of American healthcare has been our different pricing level relative to other countries and over time. And there is this widening gap now between what private payers pay and what public payers pay. And you can debate it all day long about is cost shifting, it's not cost shifting, it's real. And it's a phenomenon that really underlies the financial engine of American healthcare. Next, please. So, I would say, and having been an advisor to large employers over the years, most employers are kind of complicit in this game. They're not thrilled about it, but they don't really do much to stop it, with some rare exceptions where they've kind of massified their firepower or used their influence to create narrow networks. And the question is, will they stiffen their resolve here in the post-pandemic period as they have been hit hard, many of them, in terms of their own core businesses? Next. What I would say is that if I had to give a talk about trends in healthcare prior to the pandemic, the top trends really were the kind of confluence of what I just described, the rising commercial prices and financial gotchas and things like surprise billing, which, by the way, is not a bug, but a feature of certain business models like emergency room physicians who have been rolled up by private equity firms. The second mega trend was the growth of Medicare Advantage, which I think has been one of the engines of the value movement in American healthcare, as has managed Medicaid. And of course, Medicaid expansion in the wake of the ACA was the fact on the ground, I think, that really expanded coverage. But similarly, what we've seen prior to COVID, and I think will actually accelerate and perhaps even become a bigger force is consolidation in the healthcare delivery system and the market power that it creates. And I say inevitable partly because of not so much that it's a good idea to consolidate, but that a lot of weaker players may capitulate. And there is a massive amount of money prior to the pandemic and even through the pandemic being invested in private equity and venture funds in healthcare, particularly in consumer-facing digital health, but not exclusively in that area. And in the political realm and the policy realm, there have been prospects for Medicare for more. I wouldn't say Medicare for all necessarily. I'll defer to Bob Blendon on that. But certainly the possibilities in a Biden administration, had there been a substantial Democratic Senate majority of a public option for many Americans and an expansion of Medicare to younger age ranges. And I would say that value-based care is what I would call a stalled future. It's not that we don't believe in it, and certainly, I'm an advisor to Levitt Partners and a great fan of Governor Levitt and his team, and share the commitment and belief that value-based payment needs to be the inevitable goal of healthcare. But most of the action, I believe, has been in Medicare and Medicaid rather than has been in the commercial, particularly self-insured employer space. And that remains the frontier to be tackled. And of course, many health systems across the country were responding to new consumerism movement in healthcare and trying to create a digital front door. And I believe that there is a force for productivity in healthcare through the rising promise of artificial intelligence. And I think that may be one of the things that will bail us out in the long run in both the clinical area with innovations like dermatology or surgical pathology, imaging, ophthalmology, pattern recognition done with and enhanced by computers, as well as in the more administrative area. And the final mega trend I would point to is the whole area of physician burnout. And I think burnout is the wrong term. I think the term, everybody works hard, right? Clinicians like to work hard. I think that the sense of alienation and frustration that many folk feel and demoralization in the face of sort of unnecessary administrative hassle factors has been a big driver. And this has obviously become more intense post-COVID because of the sheer terror legitimately that many caregivers face every day in the face of dealing with patients who are sick and infected. Next, please. And maybe just a couple of data points behind the sweeping rhetoric. It's interesting to me as a person who, is a fan of Medicare Advantage that we have seen even in the Obama years, which, with Democratic administrations, we're not as gung-ho about Medicare Advantage. We saw continuous growth, and I believe, certainly my colleagues at Levitt Partners, I think, believe that this will grow materially over the next decade, regardless of national policy. The other sort of counter trend is Medicaid expansion, even with Republican administrations, and even in the Trump years, we've seen states expand Medicaid. Most recently in Oklahoma and Missouri, who are not noted as being hotbeds of socialism, and yet vast majorities of their population voted to expand Medicaid. Next, please. So COVID brought challenges to the health system and continued to do so. We have been obviously trying to focus on stopping the spread and have had uneven results in that. I think we've done quite well in serving the sick and learning how to do better. I'm not a clinician, and it would be impertinent of me to weigh in on that, but certainly some of the success stories have been remarkable in terms of being able to get the fatality rate down. But the real challenge, I think, remains how to balance the economic issues with the clinical pandemic. And it has proven very difficult, not just here in the US, but around the world in starting economic recovery. And I think most people have done it somewhat prematurely and have had to reassess their progress. Even my native Scotland in the last month or so is basically shut down again. Next, please. And of course, the challenge really, and certainly the president through the early part of the year, was focusing much more on the rebound from the precipitous drop that took place in the economy in the first 6 months of the year. Historic drops in jobs. If you go to the next slide, what we saw was basically all the jobs created in the last 20 years disappear in 2 months, which was massive and impactful across the board. Next. But we have seen significant recovery since then. We're down about 10 million jobs kind of year over year. Unemployment rate has bounced up to 6.9%, but it's higher for women and it's higher for minorities. Alarmingly, a significant proportion of those who are now unemployed have been out of work 27 weeks or longer, which is always a bad indicator for not only the income of those households, but the social determinants of health that result. Next, please. And so it is important to consider where we go with regard to jobs, not the least of which is, will it cause us to reassess our commitment to using employer-sponsored coverage as the backbone of American healthcare? So when you think about it historically, it's kind of an accident that we do it this way, and my colleagues around the world think it's kind of a goofy idea. It's hard to explain to people in Glasgow why that would be so. And this cruel cartoon, by the way, it's a fine and dandy idea when the unemployment rate is 3.7% and everyone's got a job with health insurance, which is not necessarily the case. It's not so fine and dandy an idea when the unemployment rate is 10%. And I think one of the things I've been looking for over the last 6 months is a change in public attitudes and a sense of vulnerability the public may feel about their employer-sponsored coverage. Next, please. And I do want to point out that this pandemic, not only in terms of jobs, but in terms of the impact on the actual clinical outcomes, including deaths and hospitalizations, have disproportionately affected the folks who take the early bus. And we've seen a bounce back in income. And those of us who Zoom for a living are relatively unaffected and doing very nicely, thank you. Those of us who live off capital rather than labor have done very well in the last year. But if you are a bus driver or a hotel worker or work in a restaurant, that's not the same story. Next. Sadly, this has been, as I say, compounding the effects of race and racism show up in these alarming differences in mortality rates and impact by race. Next. So, my colleagues and I, we worked on some scenarios back in March to try and describe the arc of what may happen. And I won't bore you with all the details, but we've used these to kind of judge the unfolding reality. And they're really sort of cartoonish. I mean, they had data behind them and sort of assumptions, but let me just describe them in sort of cartoon form. Because I think they are sort of instructive of the arc of the year so far. The big bounce back scenario was, I think, what many people were hoping for, which was it was a 1 quarter event, much as it was in China, and we killed off the virus and we got back to normal. Well, that clearly hasn't happened, except in 2 places. One is the stock market, which has bounced back and is ahead year over year. And the other is actually the health system, which I think has bounced back quite remarkably. In the last 3 quarters, even though it's been hammered by the pandemic in many, many ways. The second scenario was really presaging perhaps a blue wave where the American public felt progressively insecure because of the pandemic and would vote for more faith in government to resolve those issues. And to some extent, that scenario has prevailed with President-elect Biden's election, although there are countercurrents in the fact that there was very significant vote for the president, for President Trump, and that Democrats didn't gain massively in either the House or Senate. The third scenario is a bit like scenario 1, only it takes a little longer, and we may eventually get to that new normal later on next year. with the good news about vaccines. And I do think that the difference between scenario 3 and 1 is not only that it takes longer, but that some things will be different. And I do think in the long run, people are going to be more cautious about mobility. We're not going to travel as much quite yet. Scenario 4 is like scenario 2. It's Biden administration with no money, right? Because one of the big overarching problems post-pandemic is that the federal government is $3 trillion plus deficit, adding to the national debt with a cumulative debt over 100% of GNP. That's not a terrific place to be. And so this scenario was really around a willing administration without the ability to do anything. And that's certainly true at the state level. I mean, I've been cruelly saying that people are defunding the police or the Senate in the sense that there seems to be not much action in terms of bailing out particularly blue states at the state level. Scenario 5, I have to credit my daughter, who's an epidemiologist by training and works as a consultant, but she lives in Seattle, and I asked her at the beginning of the pandemic, what's going to happen? She said, well, they're going to close it down, and then they're going to open up again, and then they're going to have to close it down again. And she's actually been dead on. That's what's gone on, not only here in the US, but in many parts of the world. And mercifully, it looks like we're seeing scenario 6, which science will save us. All of us, I think, hoped and prayed that we would have results from the massive investment in vaccines and in the science generally, and that the news of the last week or two has been very promising. However, I would say the converse of that scenario was scenario 7, which we didn't even like to describe, which was civil unrest and no effective virus. And I have to say, I think the next 60 days are going to look a bit like scenario 7, where we're going to have people going to Thanksgiving, a third of whom say they're going to meet as if it's normal. And there is no vaccine in the arms of humans quite yet. And this false sense of security may compounded with 160 to 200,000 cases a day lead to a very ugly period over the next couple of months. I hope that's not true, but I fear that it might be. Next, please. And so just in closing, you know, I've been trying to think through what are the sort of no matter what's of all of this. I do, and I've always believed, as many of my colleagues do, that science will save us. We just didn't know when. And it looks like there may be hints of normalcy by the back end of next year. I actually believe that unemployment is still going to be down for some considerable time, and I'm not alone in that. I think the Federal Reserve believe that too. And I've gone out on a limb in saying that January 2020 was probably the all-time high of private insurance in America. Because if you look forward demographically, the economy is good at generating low-income jobs that require subsidy for insurance. And also, you know, you've got this aging society where more and more are actively on Medicare, and that potentially could have access to it through policy changes. I think Medicaid coverage is likely to grow in any scenario, and that sort of further, as the virus has, exposed the financial hydraulics of American healthcare and the overall dependency on procedure-oriented fee-for-service, surgical in particular, activity to make the math work for all providers. And I do think there's going to be high anxiety amongst patients and families, not only about healthcare, but also about travel and other industries. If there's a positive in the pandemic, it's been the amazing speed and resilience people have used to pivot to digital activity, not only in health, but in all areas, as evidenced by us gathering in this format. And I only hope that we don't just pave the cow path, as we futurists like to say, of just replacing visits with televisits, but rather use this moment to do a fundamental redesign of healthcare clinical processes end to end, to be much more rich in their digital mix going forward. And one last slide, I believe. Thank you. I would hope, and you're going to hear from a distinguished panel coming up. But I would hope that we take this moment in our history to pivot towards a longer term future that is more based on value-based payment models and principles, that we take this chance to redesign our care processes, to embed more digital mix in telehealth and virtual care, and that we rethink and integrate better funding of public health, behavioral health, social services, and healthcare going forward. I've long believed, as people like George Halverson have, that the end game for American healthcare might look like something on a bipartisan basis that you might term Medicare Advantage for all, supported, tax financed, but having elements of competition that would be a unique American healthcare system. I think there is still the possibility of that, but certainly, in a polarized and divided country, it's hard to see how that happens in the short run. But with the great leaders you have, Sarah, I think, if anyone could pull it off, it's America.
Well, great. Thank you so much, Ian. And that was a real tour de force of really a lot of insights. And so I'm really excited now we can get into a little bit of Q&A. I want to start with what you talked about here in terms of kind of advocating for the opportunity to take a fundamental redesign of clinical processes. And I want to just acknowledge, something about the pace of change. I mean, no matter what we think of this pandemic, the upheaval and the pace of change has been tremendous in terms of, just like the rapid adoption of telehealth and those sorts of things. But at the same time, kind of as you pointed out, the whole value agenda has kind of crept along and crept along and crept along. Given the financial challenges that are facing providers right now, given, the statistics you mentioned about just the incredible wage gaps that we have, how that's going to translate to coverage, and then how that's going to then translate to kind of the differential between public and private payment rates. I mean, how do providers, and I'm speaking very broadly here about providers, like how do they take that step? What's their incentive?
Right. Well, I think that's a key question. I mean, I've since the pandemic has been raging, done a lot of advisory work with health systems and particularly large physician groups too. And what I would note is that those who had value-based payment models, whether they be capitated or in some kind of prepaid arrangement, I'm thinking of my friends at Kaiser, obviously, but also folks like the Henry Ford Health System in Detroit, who I work with recently. I mean, those payment models prove resilient through the pandemic, but there is a counter trend where most American healthcare is still predominantly playing the game I described at the beginning, right, on a fee-for-service basis. And what I also see, it's my joke about we're not moving from volume to value, we're moving from volume to volume, from inpatient volume to outpatient volume. And I have to say, I sit through these board retreats and they're celebrating massive increases in utilization when they occur, right? So there is an addiction, if you like, to that fee-for-service engine. But you mentioned another point I think that's critical. I have been in actually reverential awe of the leaders of many of these large hospital health systems across the country, the resilience that they have shown and the speed and agility they have shown. I mean, I've been a critic of the industry for 30 years and always teasing them that they move at the speed of glacial erosion, normally. But they've actually, in many, many instances, done 20 years of innovation in 20 days. It's been really quite remarkable. And I just hope we can make that time clock of, hurry up offense a little bit more permanent in our health system.
Yeah, and how do we take that? I just want to follow up on that point. 20 years of innovation in 20 days, pretty remarkable. Like, what mechanisms are there? How do we learn from that? How does the health system kind of translate that into something that sticks?
Yeah, I think that's the key point. I mean, I did a panel with a number of CEOs just a few weeks ago where all of them in their own way described that transformation and resilience and stressed obviously that part of it was building a culture of decision making that was much more rapid that they hope to make permanent. But they also, I think these leaders who have been around a while, recognize that you can't be constantly in panic mode. Battlefield medicine was kind of what we were practicing in many parts of the country at the height of the pandemic, and presumably right now with some of our colleagues in the Midwest, and we feel for them. But you can't keep that pace up forever, so I think it's balancing on the one hand a renewed sense of agility, and on the other not to stress or overstress your people and your organizations.
Yeah, so on that point, you mentioned as three of your mega trends: physician burnout, consumerism, and AI. And you even mentioned, you think AI has a really important role to play here. Is there some kind of coalition that, not a formal coalition, but I mean, is there a world in which kind of the angry consumers that are, they want the more convenient care, the providers that are just exhausted, and the technology can kind of come together and in some way help to advance our health goals in this country?
I think that's a very positive framing of what could happen. The potential. I mean, here's the challenge. Historically, healthcare has proven kind of immune to technology improving productivity, right? If anything, technology has made it more expensive, not less expensive. And I think AI represents a real, and I'm not talking about replacing doctors. I describe clinical AI as hamburger helper for doctors. It makes a scarce resource go further, right? But that can enhance productivity dramatically. And where there are potentially massive improvements, because remember, we have the most bureaucratic health system in the world, right? In terms of people in offices faxing things to each other. I think there could be dramatic improvement through AI in the administrative processes, both internally and throughout the health ecosystem, so that we don't have armies of people doing revenue cycle, for example. And I think that's where we could see significant improvement in productivity in our institutions.
Yeah.
And you mentioned the third piece, which is consumers looking for cheaper solutions are maybe going to settle for chatbot services as a front end of primary care. And I'd watch for that. There are a number of entrants, both domestically grown and entering from other parts of the world, who potentially could revolutionize the sort of economics of primary care using AI.
Yeah, thanks. And you said something which we don't hear a lot, which is fax machine. And maybe we just need to like ban fax machines as a starting point, and then
the fax machine should have been out of business 30 years ago. It's
anyway, no offense to the fax machine manufacturers.
See fax machines. They have to teach students in medical school how to use a fax machine, and none of them have ever seen one.
That seems like a waste of time. So I want to also ask you about the health inequity. I mean, there's you started off by talking about the income inequality, which has only worsened as a result of COVID and the way that the economy has turned. Obviously, we've seen these huge inequities. I mean, how do you think we begin to sort of find our way out of that and towards a better future?
Well, I mean, I can just give you one example. I'm proud to serve on the board of the Martin Luther King Hospital in Los Angeles, which came back from being closed in the early 2000s for a whole bunch of reasons, and was rebuilt, reformed, and reborn to serve the community. And I have to say, Elaine Batchelor, our CEO, and the team have done an astounding job through the pandemic in responding to COVID. And we were probably 60% COVID at the height in July, and have weathered that storm. And there is a bit of a resurgence the last week or two. But I would say this, that I think MLK is an example of investment by federal, state, and local government in providing a beacon of quality in an underserved community. And I think we need to think more imaginatively, like I believe we have at MLK and the leaders who created it, to find a new way to bring resources to underserved communities that lift them up and give them hope for the longer run. I think it's going to happen one community at a time, but we need a national policy that encourages it.
Yeah, thank you. And I just want to ask you a couple more questions. I mean, one, you talked about Medicare Advantage for all as maybe being a very, very long-term kind of end game. It just seems like, and we saw this in the debate, we saw that, the Medicare for all model was obviously roundly kind of defeated in the Democratic primaries, but we have such a discomfort still in this country, or we have just not settled around the proper role for public and private. And personally, I think if anything, if we learned anything in COVID, it's just like the importance of both sectors. I mean, you see it with the vaccine development, you see it with, the efforts both on the ground with the public health departments, and then with private sector efforts, which we're going to talk about a little bit on our next panel. I mean, how do you think the public sector and the private sector respectively need to step up to meet this challenge?
Right. Well, I mean, I think the great Bob Blandon would probably say that one of the distinguishing differentiation between the red and blue teams is their belief in the role of government and the ability of government to pull stuff off. So I think we are more divided than any other country I've lived in or studied in that measure about the belief in government. Canadians, I'm married to a Canadian. My son was born in Canada. I have a lot of family members in Canada. They're different from, I always say Canadians are different from Americans. They describe themselves as unarmed Americans with health insurance, right? I mean, but they believe in government more and the power of government. And I think that's why I hope that we can find some common ground around something like Medicare Advantage for all, because it takes, it concedes to the other side that on the one hand, universality is important, and on the other, a role for competition, and the private sector has a legitimate role to play, and that those are ideological decisions that a divided country have just got to get over and find a way to work together. So I think it can be done. If you look at the Australian system, for example, I believe that that might be a better model than thinking about Canada, where you've essentially got a base where everyone's in the same primary care system, but you have the right to trade up with your own money, not to a different level of outcome, but to a little bit better amenity. And you get employers out the way, and you make that a consumer choice. I think there are ways in which you could build what I've called a floors and ceilings model, where you have a basic floor below which no American falls, and the right to trade up to certain things for your own money, provided those differences are not dramatic in terms of clinical outcomes or health status.
Great, thanks. Well, Ian, just in closing, sort of the words new normal have come up, various times over the last few months, and I know it's a little hard to tell yet. Like, do you have any guesses as to what a new normal in healthcare could look like in this sort of near term, like next couple of years?
Well, I think, I was on with the board of an insurance company just a couple of days ago, and one of the things that came up was one of the board members ran a medical university, that trained allied health professionals, and she was telling me that since the pandemic, there has been an explosion in interest of people wanting to get into the healthcare system, not as a money maker, but as a calling. I actually think that one of the things that we will reflect back on is what this has done to public attitudes towards caregivers, to health professions. And in actual fact, I think while we're going through this very difficult next 3 months, we will probably emerge on the other side celebrating our health system greatly, which will make it maybe a little bit more difficult to, tamper with the game, if you like, from a policy point of view. But I do think the upside of the pandemic will be if we can use and harness the engine of innovation and the speed and agility of reforming to change the way we deliver care that's more humane, that's more equitable, and that's more innovative, quite frankly, going forward. That would be a good new normal for us to achieve.
Thank you, Ian. Well, with huge gratitude to those who are on the front lines caring for COVID patients, trying to prevent those cases, who are working in the labs to develop the vaccines and the tests and the treatments. We are grateful for that. And Ian, I'm grateful to you for spending the time with us at the Alliance today to talk about what the future may hold.
My pleasure. Thank you for having me.
Thank you. And with that, don't forget to join us for our next panel at noon.